Yes, so thank you for having me here. And thank you for Lynn for kind of, putting some background already. And if I run out of time, at least she talked about some of the issues. So, this past weekend, I was at a health fair for Armenian community, and I was sitting at this GYN REI table, and there were these older women passing by. So like, honey, what are you doing? Well, I'm GYN, and I can talk about infertility. And they're like, oh, thank you, darling. No. And I was like, I really wanted to tell them, we can talk about pregnancy still, It's like, I can help you if you want, but I didn't. So let's talk about motherhood at any age, what we can do, and actually what should we do, right? I think you probably talked about this, but I came late. Anyway, so we have pretty good idea about natural fertility in general population, right? And this graph comes from, and so the first graph actually comes from early 90s from religious sect in North Dakota when they didn't use contraception. And you can see that there is peak fertility is in early 20s, and there is a natural decline in fertility, what we say to our patients usually after age 35. And then the second graph is also pretty similar, but these are live birth rates that we see in our clinical practice when we treat infertility with assisted reproduction from 2013. And it's pretty much mirrors of what we see in general population. This is another well-established fact that Dr. Westwell talked about, that there is increased rate of aneuploidy, meaning having chromosomally abnormal eggs and embryos with age. And that also translates into increased miscarriage rate in older women. So what can we do about it? This is pretty much similar sad graph, but with a little bit of hope, actually with great hope. You can see that here, in the upper part of it, we can actually restore this situation, right? You can see that with the event of usage of donor eggs, the live birth rates are similar no matter what age woman has. And we know now that this can continue here. You are never too old, right? So we, and also general public, they see in news, in newspapers and magazines, they see that famous celebrities, they get pregnant all the time, and few of them are vocal about it and the way they get pregnant, but some of them keep it secrecy, and it just happens magically. And patients come to us and say, so-and-so got pregnant at 50, and my cousin got pregnant at 50, so I can, and you are telling me about the decreased ovarian reserve and all this stuff. So then we have to break it to them that, actually, people don't talk about everything. So what is oocyte donation and how it came about? Initially, it was Australia that was the first. So the first baby was born from egg donation in 1983 in Australia, and then US was following closely in 1984. And very interestingly, and a lot of people don't know that the way the first egg donors were utilized was actually very strange, but at that time made lots of sense. Basically, normal healthy donors were fertilized, were inseminated with patient's husband's sperm, right? So their eggs were fertilized inside of their body. Then the embryos were flushed by uterine flushing. The fluid was coming out, hopefully with all the eggs. All the embryos. Embryos were isolated and transferred to the recipient. But of course, as you can imagine, there were lots of inconveniences with this, and one of the biggest issues was that the donors could get pregnant, which they didn't sign up for, right? So, and at the same year, because doctors were realizing all this, so the first donor IVF cycle was performed, and that kind of became a new standard. And another thing that we learned when we were using donor eggs is actually uterus doesn't really age. And in women over 40s and 50s, uterine receptivity can still be maintained with the correct hormonal manipulation. So that was also important things to learn. I guess my animation doesn't work here. OK, I don't know why. So whatever was underneath was showing the indications for oocyte donation. So the main indications that we use is advanced maternal age, right? When women kind of run out of eggs. Another one is, or let's say menopause, right? There are no eggs anymore. Or diminished ovarian reserve. There are some eggs, but they are not enough. Or patients have failed multiple IVF cycles, or they do not produce any normal eggs and normal embryos. POI patients, premature ovarian insufficiency patients, for example, or couples or patients, single males that don't have, there's no female in the equation. So that's another indication for using donor eggs. So it's kind of valid alternative to adoption. Oocyte donation, I told you how it started, right? And then with improved techniques and which I kind of briefly will talk about, there is increased use. It's easier for doctors, it's easier for patients, for like intended parents. It's also became easier for donors. So we, initially when donor egg was started, so the way it was working is, the idea is we do the IVF cycle for a donor, we retrieve eggs, then we fertilize the eggs with partner sperm, and then we have to transfer these embryos in the recipient, right? So the cycles have to be synchronized because we know that uterus has to be prepared. Human endometrium does not accept embryos at any time, so the uterus has to be prepared. And that's why, and also because the freezing techniques were not as good, so everybody was still using the slow freezing that we all heard about. So it was very important to have this possibility of hormonal manipulation of the cycles. So kind of one of the breakthrough was when GnRH agonists have been used for synchronization. Ultrasound-guided egg retrievals also helped very much. Initially, the egg retrievals were performed through laparoscopy, and that was kind of a big deal, you know, for donors. And then also, nowadays, there are lots of agencies and lots of different organizations that actually help with recruitment of donors. So there are increasing numbers of donor cycles that are performed in the US. And in the world as well, however, I have to mention that there are many, many countries that actually restrict using donor eggs. So there are also certain parameters that we need to follow. So the donors should be preferably of legal age. They should be ideally between 21 and 34. Patients can select their donors. Donors can be anonymous, and that's most of the donors that we have. Or they can be known or directed. Often they are sisters or cousins, occasionally best friends. In that case, the upper limit of age can be lifted, but then, you know, recipients have to be informed about potential effect of age. So in that, you know, if you want to use your sister who is 38, you may not get as good eggs. Donor is screened to confirm the good candidate, and I will talk about this later. Recipients and donors' menstrual cycles should be coordinated with medications, but nowadays it's performed less and less because we can freeze embryos very successfully, and then the recipient can get her frozen embryo transfer anytime she wants, and kind of in an easier cycle. And as I said, you know, donor is going through IVF cycle, gets her eggs out, fertilized, and then prepares, and then the recipient is prepared for transfer. So there are several things that we are screening donor eggs for, and we are doing our part by doing history and physical exam. We are evaluating ovarian reserve because you don't want to accept a donor who actually has very few eggs and will not provide, not kind of serve the purpose. We get extensive family history. We do infectious disease testing. You basically want to make sure that the donor will not be a source of any communicable disease. And we get informed consent. Genetic screening is performed, and nowadays, when we have this expanded genetic screenings, we actually test for more diseases than we were doing a few years ago. We use now this council panel that I think for most donors we use that covers about 176 autosomal recessive diseases. And also, they get very kind of detailed psych evaluation and by certified mental health providers. And also in case of non-donor, also it's important to kind of evaluate for possible evidence of coercion, financial or emotional for these people. proven fertility is desired but not required. And by proven fertility, sometimes we mean if she has been pregnant before, or it's kind of experienced donor. Has she donated before? And if there is a pregnancy that resulted from previous egg donations, it's a good sign. We prefer to use these donors. These all screenings are kind of governed by FDA rules. And we do perform this FDA donor eligibility testing. And we have to make sure that donor has no evidence of communicable disease, no risk factors and no clinical evidence of it. So they usually have to test within 30 days for these diseases. And our questionnaire now is pretty kind of expanded. We have about 2 pages. And the recent inclusion was, of course, Zika virus. So recipient also has to be screened pretty significantly. So because this is the person that will be attempting pregnancy and will be getting pregnant, and we know that a lot of these patients are of advanced maternal age. So we get history and complete physical exam. They also undergo psychological evaluation because they also should be aware of what is it to have a child that is not biologically related to you. Right? I do talk to patients about, okay, genetically this child is not related to you, but think about epigenetics and what your body does for this. So it kind of helps them to maybe feel better, which I think epigenetics probably plays some role there. We also have to perform uterine cavity evaluation, and that's kind of a routine thing that we do for patients that undergo IVF and embryo transfer to make sure that before we put this precious embryo back, the uterus actually looks as good as it can be. And standard preconception testing and counseling, of course, because these are patients attempting pregnancy, infectious disease testing, and we also test, of course, oocyte recipient's partner, because this is the person who provides sperm. So sperm, semen analysis, and infectious disease. And as you can see, the recipients of donor egg can be of any age. And younger patients usually are our POI patients, most of them for POI for different reasons. And then, it picks up by age 36 probably and up. And this usually most prevalently is diminished ovarian reserve, premature menopause, or just unsuccessful IVF cycles with own eggs. So is this procedure, does it have any risk for a donor herself? Like, why are donors doing this, and is it safe for them or not? It's overall safe process because it's very streamlined. We are kind of very experienced and provide good care. However, of course, there are some risks. Blood drawing has theoretical, but has some risks. Ovulation induction agents, they potentially in egg donors, they can cause hyperstimulation syndrome because these are potentially patients that have good ovarian reserve and can, at the same time, simultaneously grow big number of follicles. So now we have very low OHSS incidence because we are very much aware of these risks and we prevent OHSS in our patient population. Egg retrieval is a surgical procedure when we basically put a needle in a pelvic cavity. So yes, technically there are 0.5% or less chances of infection or bleeding. Can be psychological issues, mostly regret, for example. There is anesthesia risk. We provide antibiotics. Occasionally can be some allergic reaction to antibiotic. These patients could be at a risk for ovarian torsion, and we counsel them very strictly about what they can and what they should do after the retrieval. Patients usually are interested to know the long-term effects, all patients, not only donors, but in particular in donors, it's good to know if there is any cancer risk for these patients. They do completely, elective procedure. Is there any effect on their future ovarian reserve, their future fertility? And today, there's no evidence whatsoever that there is actually increased risk for cancer. And mainly, we're talking about breast and ovarian cancer, and there is no effect on ovarian reserve. As Dr. Westphal mentioned, the eggs and follicles that we harvest are not the ones that can be used by patient or by woman next time or next month. These are the ones that are destined to become atretic anyway. So that's what we are trying to harvest. So there is no effect on ovarian reserve. Okay, so I don't know if you heard about using frozen donor eggs, but this is a new trend. And this new trend came about because we have good, good experience with freezing techniques, and because the freezing eggs is no more experimental. So that's kind of why we actually have this, and we can offer this to our patients. Using frozen donor eggs and fresh donor eggs have comparable success rates, and that's why it's so valuable. It can provide some convenience because if you can imagine, right? So if you choose so-called fresh donor, so you have to select a donor. This is a live person with her own schedule in life. She has to provide kind of timing when she's ready to go through the cycle. She has to undergo the screening, and maybe she will be rejected, but mostly not, but maybe. Then she has to undergo this IVF cycle. Embryos should be created, et cetera, et cetera. So when we have frozen donor eggs, they're already there. They're already in a bank. The only thing that patients need to do, they have to choose the donor egg and kind of, sign the contract, purchase, et cetera. So it's much faster and convenient. It can be cheaper because when you buy, purchase or whatever, when you get the donor eggs, usually you don't get everything that the donor gave, but you actually probably just get 6 to 8 eggs, enough for 1, maybe 2 children. And that's good for people that don't want to have big family with egg donation. Then people will have, because there is, when you get 6 to 8 eggs, maybe you will have 1 or 2 embryos. So you'll transfer 1 embryo, maybe get pregnant, and then freeze another embryo. Or maybe you don't have anything to freeze. There is less embryos frozen and less issues for patients afterwards to think about what, what do I do with the embryos that are left there? Because some people don't like thinking about discarding them or donating, et cetera. So that's kind of less problems for patients. Maybe that's also better usage of eggs, because now we have a lot of donor eggs and maybe embryos created with donor eggs sitting there in the banks around the country that will never be used, because people already, they use the fresh donors, gotten like 10 blastocysts, got 1, maybe 2 kids, and that's it. All these other embryos are sitting there. Donors come, and if everything is successful, they had good experience, no complications, they want to donate again. And so ASRM does recommend to limit number of egg donations to 6 per donor for the lifetime, if actually we can follow them. And that's mostly to protect the health of the donor because of these possible complications, and also to avoid issues of consanguinity, especially if the donor is in this small area and not moving and always donating in the same area. Another issue here is that these are 6 cycles per donor, but per each cycle there are more eggs and more embryos that are created. So there are, of course, more babies that are created with this 1 cycle. For example, SRM recommends to limit 25 for donor sperm, to limit 25 donations per sperm donor, if we can control it, of course, right? So it kind of maybe equals to this even. I think will be more kids from 6 egg donations. So what about compensation? The donors in the US are compensated. In different countries, especially in some of the European countries where donor egg is allowed, it's only altruistic, okay? But the US largely is allowing compensation. Although per ASRM, it should be reasonable, because the compensation should not be the reason for donors actually to go for this procedure. And it's more payment for time and the discomfort and not for eggs. And also, people are also afraid that, if it's high payment for donors, which of course recipients should pay, then it also only will limit the usage by just wealthiest people. And it also may, if there is no regulation, it may actually allow to provide higher payments for some preferable characteristics. We're not going there. Okay, so now I'm moving to the second part of my presentation. I think okay. Surrogacy and gestational carrier. Her body, my baby, right? So now we're kind of using somebody else's uterus to carry baby for us. Indications for surrogacy are, I think, usually pretty obvious, right? If there is no uterus, it can be congenital or acquired, Mayer-Rokitansky syndrome, hysterectomy, like cesarean hysterectomy, or it can be a male partner, single male or male gay couple. Or uterus is unable to sustain pregnancy. So one of the common indications for using a gestational carrier is recurrent recurrent pregnancy loss. And then previous, for example, radiation to the uterus and Asherman syndrome. Situations when pregnancy is medically contraindicated, for example, like pulmonary hypertension, or is kind of really not recommended because of exacerbation of the disease, like cardiomyopathy. And again, it's increasing numbers of cycles of gestational care are used in the US. Here are different kind of perturbations of who can use the gestational carrier, and also, how we can play around eggs and sperm. So, so we can use here own egg and partner sperm, and then transfer the embryo to gestational carrier. Donor egg and partner sperm, transfer to gestational carrier. Donor egg, donor sperm, or own egg and donor sperm. And then another, so this kind of, everything that we can do and everything we actually provide. We have to have some definitions straight. We kind of always interchangeably use these two terms, gestational carrier and surrogacy. And so as general population, but I want kind of to be straight on what is what. Traditional surrogacy, when we say surrogate mother, so traditional surrogacy is when woman is inseminated with partner sperm. Then she gets pregnant, then she carries the baby, and theoretically gives the baby back, right? So she is biological mother, so she provides eggs and uterus. That's a traditional surrogacy. We are mostly talking about gestational care. Traditional surrogacy is not really used anymore. Gestational care is what we usually talk about. When the intended parents supply the eggs and sperm, it can be from donors, but it's not the carrier's eggs. Gestational carrier provides uterus only. She only carries. She is not related to child genetically at all. And the first report was in 1985 in the US. So there are also, of course, strict criteria, and the FDA regulates that as well. So the surrogates or gestational carriers, they have to be of legal age, preferably between age 21 and 45. 45 really is upper limit. If we can, of course, we try for the pregnancy complications, et cetera, to have younger gestational carriers. Preferably, these surrogates have to have at least one term uncomplicated pregnancy. They should have no more than total of 5 deliveries and no more than 3 C-sections. So we do have sometimes, that repeat surrogates, et cetera, that come to us, or, for example, intended parents have used this gestational carrier before, and now they want to use her again. She had 4 C-sections before. So that's kind of, then we have to kind of have this individualized approach, but the guidelines, the recommendations are no more than 3 C-sections. Should have no significant medical illness, because what we are doing here, we're actually thinking about the gestational carrier's health and how her pregnancy will go. And usually, these women had uncomplicated pregnancy, so they think everything is fine, but we know that things can go wrong. So that's what we try to prevent. Intended parents also, they have their best interest in mind, so they are very biased. Also, of course, gestational carriers have to have STD screening. They should be ideally in stable relationships, should be kind of, have normal, stable life. If they have a partner should be involved in all the counseling. And they have to have normal uterine cavity evaluation, should be able to get pregnant and carry the pregnancy. Gestational care, of course, is selected by intended parents. And so the way it works, they select them, then all the preliminary testing should be completed, and there is kind of very heavy legal paperwork involved. That's, there are special lawyer teams that work with that. Then intended mother, whoever is providing the donor egg, is undergoing IVF cycles. Eggs are retrieved. They are fertilized with the sperm, and nowadays we freeze again. Before it was, as in case with a donor egg and the recipient, there should be IVF cycle and then synchronized to the recipient cycle so we can do fresh transfer. Nowadays, we don't do it as much because for convenience, it's easy to freeze. Another thing that nowadays is very common, and usually it's also required by surrogacy agencies to have the embryos genetically tested because they want to have normal embryos to be transferred to a gestational carrier. Because if gestational carrier has a miscarriage, because it was aneuploid embryo, then kind of gestational carrier will be labeled as failure, having a failure. So they want to have the best chances possible. So we create embryos, we test them, then we freeze, and then we prepare the recipient for the gestational carrier for transfer. So of course, intended parents also have to have certain topics discussed with, right? So they have to know about alternative options, for example, adoption. They have to know about the potential medical, psychological risks for the gestational carrier. And then also, for example, psychologists do discuss this degree of involvement with the surrogate during the pregnancy and delivery, and it depends on different couples and the relationship they have. They do also have to have legal advice and their lawyers because all contracts should be actually straight before the process even initiated. Also need to discuss what will happen if you have multiple pregnancy. What will happen if you have a child with problems. Another thing that we and also the SRM feels important is that everybody should understand that the gestational carrier's right to make choice to her body over the rights of the intended parents. As I said, intended parents, they are very biased, but still, it's the right of gestational carrier to do whatever she thinks right for her body. But things should be discussed in advance. What will happen if there is a twin pregnancy? What will happen if there is a abnormal ultrasound or genetic screening and we need to terminate? So things should be discussed before. Things that we need to discuss with the surrogate. Number of embryos transferred. Dr. Westphal kind of touched upon the topic of single embryo transfer that now is pretty much what our kind of preference is to perform single embryo transfer, especially of genetically tested embryos and blastocysts, to decrease the incidence of multiple pregnancy. And the same even more applies to a gestational carrier. So we have to discuss with the gestational carrier number of transferred, and that's determined by the physician and gestational carrier and not by intended parents who very often want to have twins and two babies at the same time, especially that the gestational carrier, this whole service is very, very expensive, so they want to have 2 kids at once. As I said, what if you need amniocentesis CVS? Would you allow this to be done? What will happen if you need multi-fetal pregnancy reduction, if there is abnormal pregnancy? These things need to be discussed. If there is an issue of termination of pregnancy, what if the gestational carrier is against termination? What do we do now? C-section versus vaginal delivery, is she allowed to refuse C-section if doctors think she needs C-section? Lifestyle modification. If she's smoking and drinking a lot of coffee or using drugs, we probably wouldn't accept this, but anyway, it's kind of to talk to her about it, like, are you willing to give this up? Restrictions on some activities. What is the effect on others? If she has children, especially bigger ones, they will know that this is not their baby, not coming back home and not being their sibling. Co-workers will be asking, trying to do baby shower maybe, what the partner's opinion is. And then also medical risks of pregnancy. So, as you can imagine, there are legal issues around it, and there have been legal problems. And first recognized surrogate, traditional surrogate in the US was in 1976. There have been many cases, but they kind of never were really public. So baby M became famous because this was the probably first case that was so public. And it evolved traditional surrogacy when a surrogate became pregnant after insemination with a partner's sperm, and then she refused to give baby back. And that was in New Jersey, and New Jersey Supreme Court finds that she is biological mother, she is kind of legal mother, but they decided that in the best interest of a child, they will award parental rights to biological father and will allow his wife to adopt the baby, right? And so they found, so New Jersey Supreme Court kind of found this all surrogacy legal paperwork unlawful, so they throw it away. But they awarded, so the couple had to adopt the baby. Then the kind of next breakthrough was in California, when here a gestational carrier was used. So, she was not biologically related, but she just carried the pregnancy, and then she refused to give a baby after all the paperwork and everything. And then the court in California actually awarded child to the intended parents, because they said that in the eyes of the court, the mother is the one who intended to procreate, who had this intent to get child and raise the child as her own. So California is basically probably one of the most friendly, surrogate-friendly states. So this is how US map looks based on its friendliness to surrogacy. Red color is a good color here. So you can see that California and Nevada, et cetera, so they are actually pretty friendly. I was surprised to know that DC actually prohibits all kinds of surrogacy. So we have patients, for example, that plan to use surrogates, and I had a patient, and then they're planning on moving to Tennessee. I'm like, I think you probably should start something here, because Tennessee is not a friendly state for surrogacy. You will need to adopt the baby there. And there are several ethical issues, and you can kind of read these questions that we will be coming back to it, and there is no real answer, and a lot of stuff is being decided when we kind of sit together with ethical people, REI people, and maybe even gestational carrier. Okay, so thank you very much for listening. I don't know if I have time for questions, but I just wanted to kind of show you this is how the journey starts at the beginning of human life, from egg, sperm, fertilization. This is how the zygote looks, development of embryo, and the pregnancy.